Welcome to It's Always Too Soon Until It's Too Late, the fourth video in a 5-part series on bereavement and grief in the nursing home setting facilitated by Dr. Toni Miles. The second series is an additional 5 parts on social isolation and loneliness facilitated by the Eden Alternative and Dr. Maureen Mikas. These learning sessions have been created for the WellbeingTREE, or Teaching Resilience to Empower Elders Learning and Action Network, brought to you by Altarum with grant funding from the Michigan Health Endowment Fund. Altarum, a nonprofit headquartered in Ann Arbor, has been in existence for over 70 years. We help federal and state health agencies and foundations improve health equity and outcomes through better systems of care. From lower income children to nursing home eligible older adults, our mission is to help those whose health is negatively impacted by social determinants. We are excited to bring you this collaborative learning platform offering Michigan nursing home leadership, staff, residents, and their families tailored learning to better understand and implement evidence-based strategies to improve social isolation, loneliness, bereavement, and grief that is experienced in nursing home communities. We hope that it is the first of many such educational sessions we're able to provide the residents and staff of Michigan homes. This Learning and Action Network, or LAN, is made up of 10 parts. These first 5 sessions were designed to help attendees to better recognize and understand bereavement and grief in coworkers and residents, better manage their individual experiences with bereavement and grief, as well as to improve their ability to help others cope with the same. So why grief and bereavement and social isolation and loneliness as topics for education? Nationwide in 2019, 17% of nursing home residents died. Bereavement in nursing homes is not a new issue with the pandemic, nor will it go away as the pandemic subsides. In 2020, deaths went up to 22%. A combination of COVID-19 and deaths of despair drove this increase. Isolation leading to loneliness, depression, failure to thrive. This is especially common among those experiencing substantial loss and is linked to increased risk of anxiety and depression. Older adults and those with cognitive impairment are more likely to experience complicated grief. The coronavirus has taken the lives of at least 162,589 residents and 2,913 nursing home staff as of January 1st, 2023, according to CMS. This is why we wanted to provide support by teaching specific strategies to better manage bereavement. And today's collaborator, Dr. Miles' ongoing work on unaddressed loss, grief, and lack of bereavement care that's needed to process morbidity and mortality associated with COVID made her the logical and passionate partner we needed for this topic. In addition to being a national expert on grief and bereavement in the nursing home setting, Dr. Miles is an epidemiologist, researcher, emerita professor, and current Pope Eminent Scholar at the Rosalind Carter Institute for Caregivers. She has been focusing on population health effects of the deaths of friends and family members for over 9 years. Her best practices in bereavement care and long-term care is the guide that has informed this 5-video series and will be made available with the videos. Welcome, Dr. Miles, and thank you for speaking with us today.
All right. Thank you, Christy. Before we get into today's topic, in the last session, we spoke a little bit about the complex soup of emotions that people can have after the death of someone else. And one of the things most people tend to overlook is anger as an emotional state that is common and has to be attended to as part of bereavement care. So I'm going to do a little sidebar before we get started on anger. Anger is not to be dismissed. It is a valuable source of energy. It gets you moving. It makes you know that you really do care. People who don't care are apathetic. That's the other A word. But anger says there's something more than you realize, like the slide says. It is a animating emotion. And so, oddly enough, it makes you feel more alive. And it's one way you can get rid of the negative feelings of anxiety. So you can use anger as an ally. Sometimes it's misdirected, but it's certainly a part of feelings that are valid around grief. It, like sadness, can manifest as body sensations. So, you're tight, your jaw hurts. Some people will have TMJ or jaw joint problems, belly aches. They can have bloating, just all kinds of stuff. Their mind is racing. It's like they can't get control of their thoughts. They have trouble focusing, and they can feel like, they're burning up or that they're freezing. All of that is anger and manifesting itself. If you lost somebody recently or not even recently, and your body's all over the place and it drives you to go see the doctor, you think you're losing your mind. In fact, it is anger, and recognizing it as such will give you strategies to deal with it and harness the energy that it creates. We just thought we'd do this little sidebar on anger, put that in your pipe from last session and use it. One way you can see anger, because one of the things we talked about last time was being able to see what grief does to you, is doing a mind-body scan. If you sit or stand and just kind of close your eyes and ask yourself, what is my body up to right now? And if you feel tense or you're clenching your teeth, these are things you can consciously see. And then once you see them, you can act on them and do something with them. If you ignore these, then you don't know why you have a headache. And it's because you're tense and your jaw's clenched. Anger can be identified. You have to look for it, just like with sadness. And why do you do this? Well, one of the things we encourage you to learn how to do is to grow around the grief that you're experiencing, and your angry self, the sad, yearning self, all of that. All of those children you need to wrap those arms around yourself and pull them in, because they're all a part of you. Here's a nice quote from Justin Cronin. As love turns to grief, grief becomes anger, anger yields to thought, and in order to know yourself. That's what anger teaches us. So don't be ashamed of it. It is not something to dismiss, like I said before, but you can't linger in it, and you certainly can't ignore it, because it will not be ignored. Get on to what we're going to talk about today, and that is one of the points I made last time. I've heard from each place that I've done conversations, is that planning is the one strategy that gives us all a way to think through the worst case scenario and somehow be prepared. Back in 2015, CMS basically created a requirement that all long-term care centers that have a direct care workforce discuss the care plans with the direct care workers. It was amazing that it didn't happen before in a lot of places. It is the direct care workforce that feels the brunt of people dying, because they are not prepared to think about it. They don't have privy, if they don't have privy to the discussions that a person has had with their family and their doctors, they just don't know what to do. In Michigan, where you guys are residing, there's a bunch of documents that you can use to lay out these wishes in print, so that not only will the staff know, but the direct care workers can know too. And it's called MI Post, POST. There's also advanced care planning, which is something that Medicare encourages and will actually pay for. These documents need to be talked about. The point of having the paper is so that people who are not present during the conversation will have something to reference. This allows the person in the bed to make their wishes known. The papers are not cast in concrete. When you make a decision, if you change your mind at a later date, you can change that. And I know in Georgia we have a thing called a POST, PLOST, and we can change that. But it gives folks, everyone involved, a point of focus, so we all know what you actually want, what you don't want in terms of care. And then while people are bereaved, they're not also feeling guilty. Here are objectives, because we got to have objectives. Communication is key. You don't talk about it, nobody knows. We cannot assume that someone knows what we're thinking unless we talk about it. So communication all the way around, and don't worry about upsetting people. This is a hard topic. People are going to get upset. But if you talk about it now, you can avoid more serious upsets later. All members of the team should know the details of the care plan. Everybody. Sometimes it might be worth your while to alert the dietary staff. I mean, anyone who works and is around a resident should know what that resident wants. And Ideally, you hear it from the resident themselves. You should have a strategy for communicating the changes in a care plan as things progress. What I learned from listening to folks in Michigan is that every building has its own set of forms. It is really important, especially people who move from building to building, to know what the proper forms are that document these wishes, where they're located in the charts, because all of this gives you immediate action plan when you walk into a room and there's someone non-responsive. Very, very important. Can't say that enough. Planning is one pathway to caring for everybody involved. One of the things I said early on in this series is you got experts in your building, and they know that this is a good thing to do because it decreases regret. Did I do the right thing at the right time? Did I do too much? Did I do too little? Those are all things that folks can worry about. If you talk it out, then at least you have a sense that you're acting in the interests of the resident. So here's your best practice. Number one, planning helps. Can't say that enough. Can't say that too often. Planning will help you with your grief. You're going to hear it from someone else because I'm not the only one to say this.
Well, I think it's hard to tell someone. We do try to educate, and we have publications, and they're always a help. Little snippets of advice. Doesn't have to be earth-shattering, just, common sense things. But no matter how much you tell someone, I don't think they really get it, like Donna was saying earlier, until they do it, until you go through it yourself when you lose your first resident. And then the second, and then, but just telling them your past experience, giving them the booklets, we have hospice to come in and talk, the chaplain, I think all of that, but I think it's the experience. You never get, it never gets easy, but you can handle it a little more easier, I think.
Sometimes you do have to step away. Like, I can handle it for maybe the first 15 minutes, but then after that, maybe I need to say, hey, Jennifer, I need you to go in and talk to this family. I just can't do it anymore. Maybe it's not a good day. But rely on each other and be able to talk it out. Like the CNA that had the experience with death, but still very uncomfortable with it, we sat out and we just talked about it. Then it led to another conversation, going to nursing school, so she was able to kind of build on that. Just, I guess, supporting each other.
So these are what you're looking at are people who work in leadership. There's another gentleman on the panel who's part of hospice. Some of them are administrative systems people. Planning just helps everybody care for everyone else. You can remind one another that this is what so-and-so wanted, and that provides an amazing amount of comfort. So when this film rolls, you can see that. Planning can have a structure. So it's not willy-nilly. You are setting a palette for medical care that's delivered. Now, the standard of care during an emergency, which is what happens when someone is found non-responsive, is to do everything that's possible unless there's a medical order to the contrary. And I can't emphasize medical order enough. So you must get your medical director involved in writing the orders out on the chart. And that's why advanced care planning is so critical. It basically speaks for you whether you want all care or whether you just allow natural death. All of those are in motion, but unless you do have advanced care plans, no one knows. So in Michigan, you got several different forms you can choose from. There's advanced directives, which are longerish kind of documents which spell out things in some detail. Living wills and healthcare power of attorney sort of fall under the purview of your attorney. It can be included in the chart, but that's the entity that creates them, making sure that they're legal. And then there's the DNR, or do not resuscitate orders. That order basically says, I don't want ventilation. I don't want artificial feeding. It is a very sort of I don't want kind of order. And some people find it disconcerting to say it that way. The phrase we use in Georgia, I'll just encourage you to think about using that instead, is allow natural death. And then you've opened up the gates for comfort measures and all that other good stuff. This is a process that requires a lot of intentionality, a lot of thought on your building's process, and lots of conversation. During the discussion, have the forms in front of people so they can see what will be seen in their charts. One of the things you need right away is to identify someone who can decide for you, because a lot of older adults, oh, my children know what I want, or my husband knows what I want. Not really. If you haven't told them, they know what they want for you, but that may not be what you want for yourself. And sometimes there's been a few studies on that the surrogate decision maker often is not a family member. It's someone who's friends enough to do what you want to do. Families have a hard time with letting go. That's very reasonable, very legitimate. So sometimes you have to recruit a close friend, a neighbor, someone who can say, this is what so-and-so told me she wants. I am comfortable with letting that go. And it's documented that that person that you've selected can act in that way. There's some religious communities that have those discussions within the context of their church. I've gotten a couple of stories about two brothers who found out that the father preferred one over the other as a surrogate decision maker. And the one who wasn't given the preference was kind of upset by that. But at least he knew why. His father was able to explain why he made the choice and why things were set up that way. So, because in an emergency, you don't have time for all of this. Someone has to make a decision that can be acceptable. Trauma on the survivors, the people who are standing out in the hallway or around the bed, can be reduced. The thing I learned from people that we talked to was that when you update the care plan, update the forms. So there you go. You have a legitimate time when this is open to discussion. You can change it. It's like a tickler. Do the care plan, do the end of life forms. In many different jurisdictions, there are laws about who can sign it and their use inside your building and in hospital if someone is transferred to the hospital. My favorite story is about the patient who kept his with him at all times. And so when he moved from place to place, he would hold it on his chest like this. So everyone knew that's what he wanted, and they knew what was on it. And, his wife used to get angry at him for doing it, but he felt he got his wishes known. And his kids were basically grateful because they knew what he wanted. No job is finished till the paperwork is done. You've seen that a million times. At this point in the presentation, ordinarily if we were live together, I would stop talking and I'd say, pull out the forms you brought with you, go over them line by line with people who are sitting next to you or in your group. Does everyone in the group have the same understanding of those lines? Because again, when there's an emergency, when someone has stopped breathing, you don't have time to argue about it. This is the moment you get to do whatever tweaks, or you ask questions. This slide that you're looking at is at least a 10-minute and possibly more conversation. You cannot take too long to do it. You might have to break it up in pieces. You might get the families together to talk about it. Or some places have resident councils. This might be the focus of a council meeting. You're not hastening things that don't happen by not talking about it. There's a double negative. It is worth your while talking about it because it really reduces confusion, anxiety, anger, and then everybody knows. So take 10 minutes. I'm not going to take 10 minutes here because there's other stuff that we can talk about, but you take 10 minutes and spend some time with this. Having forms are one thing, but if you've ever seen anybody, those of you who have had like CPR training or being a first responder, there comes a moment when events are in motion and you either know what to do or you don't. This is, I think of it as a technical aspect of the moment. This is another place where you can tell stories or do some reflection. One of the ways we got started on this whole training business back in 2016 was asking people what happens in your building when someone dies. And you would get a mixture of stories, but I honed them down to that moment when you think someone's dead. What do you do next? What's the next move? And some people would say, we put all the residents in their rooms, and hide them from the events that are about to take place. Some people don't have a protocol for notifying people other family members and other related folks who need to know. What happens? I think I told you the story the last time around, but it's worth repeating. I had a room with 18 people in leadership at nursing centers, and when I asked the question about what happens, half of them wanted to hide things. The goal was not to upset anybody. And the other half were along the spectrum of, they came in the front door, they should go out the front door. And everyone should know that a member of our community has passed, and say goodbye if they need to. This is a very important question because it defines everything else that goes on afterwards. When a resident dies, how do you call the family? How do you notify the family? There should always be contact information available if they're not in the room present. You have to do it carefully, because if it's completely unexpected, a family member could hurt themselves trying to get to the place where their loved one has died. So you really do have to have some sensitivity about that notification. You also want to encourage the people you talk to on the other end of the phone about posting things on social media, because it can spread things faster than maybe the wife or the spouse or the caregivers want. And so you always want to make sure that however you notify, that you respect the wishes of the person who is the lead decision maker. You don't want them to be blindsided by the news. There are other residents in the building, whether you recognize it or not, that are going to want to know. I had a friend of mine who's a geriatrician. When her father died is when she found out that he had a girlfriend in the building, that he had folks that he played pinochle with. You don't know the kinship bonds, especially for the long-term residents, that exist until they are broken. It's important not to hide it from other residents, because I don't know about you, but the buildings I've been in, they're like little gossipy units. One person eats beans, they all get gas. Does not remain a secret. And so it is really, really important. It is not a HIPAA problem. The fact of someone's death is public knowledge. You don't have to give a full medical report on why they died or what they died of, but it is very important to know, for the community's health, that someone has passed. And that likewise for the staff. There's some residents that all the staff know and they love, and when the staff are not present during the event and they come back and no one's told them, especially if they've been caring for someone, it can be quite upsetting, because staff are humans first. They become medical people, but we all start out as human beings. And your mother may tell you that she has no favorites, but we all have favorites. And so if that favorite has passed, you're going to be upset by it. There's whole literature on staff and kinship. The term we use in higher education is fictive kin. These are people we don't share genes, but we certainly share everything else. And so you need to have protocol for letting staff know if they're not present when a resident dies. You also need to have protocol for notifying the physician who directs the care. A lot of people seem to be under the impression that doctors don't feel anything. And maybe there's some who have been hardened by the process, but most of us go to medical school because we do care and we want to hear. And lots of physicians like to make a point of either going to the funeral or sending a card to the family, something to express their appreciation for the time that they've spent with their family member, and maybe telling a story that, again, your family member lives in an environment where they make all kinds of friends. Physician has stories that you may need to hear. And then the final piece, after a resident dies at some period after the event, you need memorials. Memorials are not for the deceased, they are for the living. It gives people a chance to congregate, to talk, to share stories about the one that's passed, possibly to break bread together. It is, it is a social event. Also, in some places that we've visited, it gives you a chance to acknowledge the staff who've been caring for that person. Of course, my favorite, if I haven't told you the story before, is the staff member who cared in this one place where we visited. The memorial service was also always held on Mother's Day, or the Monday after Mother's Day. And the staff member who took care of the individuals who had passed were invited to step forward so their hands could be washed in essential oils. So it is really good. Memorials are really good for everyone, and especially for staff. So, all of these things, once you get them in place and you get into the habit of doing these things, then the other residents are not so worried about dying. In places where there is no protocol, some residents are concerned because it seems as if someone just disappears in the middle of the night. And all of this tells you, no, not disappearance in the middle of the night, not an accident. This is planned, and when you pass, you will be remembered in these ways. And that also gives you a chance to add more stuff. If you want to, have somebody play guitar, you can set that up in advance. This is the social side of the celebration of your life can be just as meaningful and in planning as the medical side of things. Old people know that. It's the rest of us that are learning. Here's our best practices. They are simple. You need a protocol. And because staff turns over, that protocol needs to be taught to the new ones who are coming in the door. And it is a good idea to review your protocol with the family members of the people in your center. Some family members will argue, we don't want all that fuss. And sometimes you have to respect those wishes, but you can take that moment to remind them your relative was beloved to somebody, and that person needs these kinds of reminders. And usually when you put it that way, even the most resistant family member will go, okay, we can do this. Just, think about it in that way. And again, social media, oh my God, it was supposed to make our lives easy. It has added another layer of complexity to our human interaction. So just talk about it. Just recognize that it's a thing. Here's your moment to talk amongst yourselves. We've talked about planning. Planning gives you a role. You know what your role is. Whether you're direct care for the person who's died and you now have to deal with their family, your colleagues will know, maybe I have to offload this person's, the direct care person's load for a while, take care of these other folks. The doc is going to want to know. Everybody. This is a village. Everybody needs to know. So one of the things I want you all to talk about, if you get a chance, is, has your understanding of this changed? Have you never thought about it? Or do you think about it all the time? Because that is so important. Again, take some time and think about this slide. So I am going to stop with this. I appreciate your attention, and hopefully you're talking to each other, and doing this well is as important as all the other medical procedures that you do. Very important, because it influences the morale of the entire building. It makes people either feel comfortable being in your space or worried about what's going to happen to them. And so you can set a lot of people at ease by just being attentive to these kinds of issues. In our last video in the series, we're going to talk about memorials. They're not just willy-nilly. It takes some planning. And again, you can engage. This is another way communication happens throughout the building and helps people to get what they need out of it.